think Dan went over some of these slides with you, right, on cardiovascular emergencies? No, he did.
I don't believe so.
I gotta see him first, Tony.
Dan said that he did cardiovascular.
Chuck, baby wine.
We started with it, day one, we got like few slides into the 400 something slides.
I think we went over this stuff. We went like 5 minutes.
All right. I am not going to talk to you about acute coronary syndromes. You should know plenty about MIs, right? I will just mention stable versus unstable angina. Stable, it's relieved with rest and nitroglycerin, basically. Unstable angina, not relieved with rest and nitroglycerin. Or not readily relieved, right? Isn't relieved right away. So, look at this, microvascular angina. I have microvascular disease. Never had it before I got COVID, though. Interesting. Interesting. Never had it. So now I get to take a medication called ranolazine for the rest of my life to keep my coronary arteries from spasming. My coronary arteries spasmed so much that I had EKG changes, and I thought I was having an MI. And they thought I was having an MI in the ER too, and I got sent to the cath lab. Got a nice catheter put in my wrist. It was great fun. And I got diagnosed with microvascular angina. Did the nitroglycerin in the ER help my chest pain? Yes, it did. It gave me a horrible headache. But yes, it relieved my spasming in my coronaries. Yes, intense and prolonged chest discomfort. It's horrible.
If you stop coughing.
I would too. You know.
I'm like, oh, what an ass.
It's okay, he loves me.
Only on days.
Let's talk about, real quickly, let's talk about management of acute coronary syndromes. Everybody gets aspirin unless what? They're allergic to it. I don't care if they took aspirin earlier in the day, they're on a daily dose of aspirin, whatever, just give them some more. It's not going to hurt them, give them some more. If they're allergic to aspirin, don't give them any aspirin. Do they need oxygen if their SATs are above 94%?
Yes.
And why don't they need oxygen if their SATs are above 94%?
They're straight chilling.
So, yes, so oxygen has been shown to cause vasoconstriction. So, don't give patient oxygen that doesn't need it. Don't give patient oxygen that doesn't need it. If their SATs are greater than 94%, you don't need to give the chest pain patient oxygen. Don't give them oxygen to make you feel better. If their SATs are greater than 94, they don't need oxygen. Yes, we're going to do a 12 lead. Wonderful, wonderful. Let's talk about nitroglycerin for a second. Nitroglycerin, does it fix the MI?
No.
Tell me what nitroglycerin does. Vasodilates what?
Coronary arteries.
Really?
All arteries.
Does it? Really? Okay, all arteries. All right?
Yeah.
All arteries. It's not specific to the coronaries. And what is arteriosclerosis?
Build
Build up of plaque within the arteries.
Arteriosclerosis. Yes. Atherosclerosis is a specific type of arteriosclerosis. Arteriosclerosis is hardening and thickening of the walls and arteries. Atherosclerosis is what? Buildup of plaque. Buildup of plaque. So can someone have atherosclerosis without arteriosclerosis? No. No. No, no, no. Atherosclerosis is part of the disease process of arteriosclerosis. Does nitroglycerin dilate cement? No. How can you dilate cement? How can you dilate arteries that are stiff and plaqued in? You can't. With nitroglycerin, what do they have to do? They have to go in and they use a balloon and try and force it open, and then they put a little spring mesh stent in to keep it open, and those of you that have done cath lab, maybe you've seen that happen already. If nitroglycerin fixed the problem, the patients would just go home on nitroglycerin. So this is why I'm telling you this. How many of you currently work in the field? How many of you have seen dumb paramedics sit on scene to get that IV, to get that first nitro in? Dumb, stupid, dumb, 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 dumb. Where does the patient need to be? The cath lab. The patient doesn't need that first nitro that's not going to save their life. Look this up for yourself. Look up studies that have been done. Mortality studies have been done with MI patients. Nitroglycerin does not improve mortality in patients having an MI. Does not improve mortality. Well, why do we give it then? It's an adjunctive therapy. If somebody's having microvascular disease, if somebody's having Prinzmetal angina, if somebody's having ischemia, can nitroglycerin help with those things? Yes, they can. If somebody's occluded and infarcting, nitroglycerin does not help. Well, it improves collateral circulation. Well, you know what I say? Bull fucking shit. Because if collateral circulation was so great, the patient wouldn't be having the MI in the first place. So do not sit on scene to start the IV to get the first nitro in. That's dumb. You're wasting time. Be good enough that you can start that IV going down the road. Start your IV on the way to the hospital. Fine, you want to do a quick 12 lead on scene, someone's got chest pain, do a quick 12 lead. Be there on scene less than 5 minutes with your chest pain patients. Those are one of the very few patients that I say just throw in the back of the ambulance and get them to the hospital, is chest pain patients. If they're having an MI, they need a cath lab. They do not need a paramedic. They need a cath lab. So don't waste time. Time is muscle. And 5 minutes could mean the difference between life and death for these patients. Absolutely. 5 minutes, as little as 5 minutes. So get them to the hospital. Get them to the hospital. Get good at your IVs. Do your IVs going down the road. That's fine. Give them the fucking nitro down the road, whatever. It's not going to cure them. Why do we give it? It's adjunctive therapy. Oh, I gave a nitro and the patient's chest pain went away. Well, yay fucking A. You just diagnosed them with stable angina. That's wonderful. That's wonderful. You gave them the nitro, it made them better. That's great. What does nitroglycerin do? Besides, yeah, we said it dilates. What else does it do? It reduces what? Says who?
Says my profile.
Yeah, bull, again, bull fucking shit. How does it reduce O2 demand on the heart? How? Oh, it dilates the coronaries. Well, I just told you it can't dilate cement. So how does it reduce oxygen consumption on the heart? Well, it reduces collateral circulation, or it improves collateral. Yeah, really?
Reduction of pain reduces myocardial demand.
Reduction of pain. Is nitroglycerin an analgesic?
No, it isn't.
No. So we don't use it for analgesia, we use it for adjunctive therapy. So if the patient is having coronary artery spasming, can coronary artery spasming go along with a patient having an MI? Why, yes it can. Why, yes it can. So if we reduce coronary artery spasming, we can help with the chest pain. But it is not going to fix the artery that's occluded. It's not going to save the area that's infarcting by collateral circulation dilation. It's not. People wouldn't have emergency caths. They'd get nitroglycerin and they'd say, we'll schedule the cath for tomorrow. We'll just put you on nitro for a day. What I'm saying, it makes sense, right? What fixes the MI? Opening the vessel, or bypassing the vessel. That's what fixes the problem. So, sure, you can give nitroglycerin on the way. Here's another thing that I've seen dumb paramedics do. Do you have to give 3 nitros before you give fentanyl? No, dumb. Well, I gotta give my 3 nitros first, see if that works. Well, that's so stupid. Yes.
I was taught that, and I was explained that because
By who?
by
If it wasn't taught by Sean Newton, don't believe it.
Okay, but the reasoning that
Yeah,
told me
tell
was
me.
that was confusing
Tell me,
as well.
yeah.
I said, you have to give your 3
nitros because if you're giving pain management between, you're not understanding which.
Is it your job to understand? No. No. Are you the surgeon in the cath lab? No. No. That whoever told you that, dumb, and give them my phone number. Because I'd be happy to talk to them. Nitroglycerin does not cure the problem, and we don't care. Oh, I give a nitroglycerin. Patient has pain at 10 out of 10. The nitro's not fixing the problem. Fix their pain right away. We want their O2 demand to go down, so how are we going to do that? Fix their pain. What is our goal? A pain level of what? 0. Not 2, not 3. They went from 10 to 3. That's not good enough. You're still 5 minutes away. Juice them again with another 25 mics or 50 mics of fentanyl. Make them pain-free if you can. Who cares what does it, the nitro? I guarantee you the nitroglycerin is not making them pain-free. And if it is, then they're not having an MI. And if you do a 12 lead and it shows they're having an MI, the nitroglycerin is not fixing the problem. Can nitroglycerin make the MI worse?
Yes.
What if you drop blood pressure? Think about this. If we have, so remember, coronary artery disease is a global disease. When I talk about globe, I mean in the heart. It's a global disease. It's not artery specific. Now, people have varying degrees of blockages, right? You can have 99% in one artery and 60% in another, and maybe 40 in another, right? There can be varying degrees. But if one artery is affected by arteriosclerosis, all of them are affected by arteriosclerosis. So if we have an artery that is plaqued in, say 90%, so we only have this little bit for blood to get through. And then we have other arteries with varying degrees. We have one that's plaqued in all the way, right? And we drop the coronary perfusion pressure. What happens to the amount of blood flowing through this little opening?
It drops.
Oh, and what if this artery is perfusing the same area that this is perfusing, and now we've dropped the amount of blood? Can you extend the MI? Yes, yes. Nitroglycerin is not a wonderful drug. What else does nitroglycerin do? It reduces two things. What? What were you taught? Nitroglycerin reduces what? Preload and afterload. Someone tell me when it's good to reduce preload. Someone explain to me why it's ever good to reduce the amount of blood returning to the lungs. Why would you ever want to limit the amount of blood that gets oxygenated?
What is?
When what? When there's already fluid in the lungs? Well then, let's reduce afterload so we can get fluid out. Reducing afterload is great. Reduce the amount of pressure the heart has to pump against to get blood out to the rest of the body. But why do we ever want to reduce the amount of pressure that's pumping blood to the lungs? For us as paramedics, why would we ever want to reduce preload? Give me a situation. Now there's conditions, right? Patients have pulmonary hypertension, patients who are hypertensive, patients who end up, they take beta blockers, right? Patients who are volume overloaded. There's certain conditions, yes, maybe preload needs to be reduced, but for us in an emergency situation, there is never a good reason to reduce the amount of blood coming back to the lungs to get oxygenated. And what does nitro do? It drops preload. Why is nitroglycerin contraindicated in a right heart MI? Because it does what? It reduces preload. And preload is already affected because the right ventricle is infarcting. Do patients normally have a right heart MI without a left heart MI? No. Normally, if they're infarcting the right heart, it's in conjunction with an inferior wall MI. So when you see a MI on a 12 lead, the MI isn't, oh, it's a right heart. No, it's an inferior wall MI with a right heart component. So you find the inferior, then you look at the right side. Oh, patient has a right-sided MI as well. Those patients are fluid dependent. If you don't continue to give them preload, they will die. If you don't get blood back to the lungs to get oxygenated, what happens? Right. You become ischemic. Your heart becomes ischemic. Your brain becomes ischemic. you become hypoxemic. So you're getting oxygen in the lungs, but you're not getting oxygen in the blood because you're reducing the amount of blood flowing back to the lungs. So this is not rocket science. Don't be dumb paramedics. Don't reduce preload in a patient that needs the preload. Nitroglycerin. Some ER nurses will tell you they don't really see nitro even being hung on patients much anymore. Tridil. Tridil. That's liquid nitroglycerin. Tridil. Guess what? Tridil. When I worked at Aerovac, if we started Tridil, we would usually start them at 50 micrograms per minute. And you can titrate it, right? You can increase it, you can decrease it. Sometimes people start the Tridil as low as 10 to 15 mics per minute. How many micrograms do we give a patient with a sublingual nitro? How many micrograms do we give? We give 400 micrograms all at one time. It's very rapidly absorbed. We blast them with 400 all at one time. IV nitro is started at a very minute dose versus what we give them orally. So I don't want to hear anybody say, well, I've seen them start Tridil. It's even contraindicated at low doses for right heart MIs. So again, you need to understand what's going on so you know why you're doing or not doing something. So nitroglycerin is not the end-all be-all for these patients having an MI. What is? The cath lab. The cath lab. Do not withhold fentanyl because you haven't given the nitro yet. I would prefer just giving fentanyl and not even giving nitro to these patients. If the patient's actually having an MI, the nitro is not helpful anyway. So what is helpful? Reducing their pain and driving fast. Give them diesel and fentanyl. Get them to the cath lab. Do you want to argue with me more?
Looking, not at the moment, I'm looking for something, but I appreciate it.
It's all good.
Yes.
If it's a load and go and they're like 10 out of 10 crushing chest pains, would you recommend like fentanyl IM or anything like that? Like if we can't get an IV, we're just going, right?
If you can't get an IV, can you give you could give fentanyl IM.
Or IN?
IN, yeah, IN, sure, yeah, you could give it intranasally. Get an IV, just get an IV. But yes, could you give fentanyl intranasally? You could. You could.
Load and go.
Please don't IO somebody just because you're having a bad IV day, though.
I'm waiting to do it.
But sure, somebody with severe. So fentanyl is not as vasoactive as morphine. So the chance of severely dropping somebody's blood pressure with fentanyl is not there like it is with morphine. So yeah, sure, you probably could. I gave a patient a big IM dose of fentanyl. She probably had a femur fracture and maybe a hip fracture, and she was in a motor vehicle crash. And she was on the larger side of the scale, like 300 plus pounds. And the ground crew, the fire agency, could not get an IV in her. And she was awake and screaming and in lots of pain. And the flight nurse tried, and she's great, and she couldn't get an IV. And I said, hey, why don't we just give her fentanyl IM? And we didn't do the IN thing. We didn't even have little attachments back then. So I gave her an IM dose of fentanyl to help her with her pain. So sure. Right? There's always going to be certain circumstances that are out of the norm that maybe you need to think outside the box. But think your nitro is your nitro and your analgesia is your analgesia. And one is not dependent upon the other. They're mutually independent of each other, mutually exclusive. So if you give the nitro and the pain goes away completely, I'll concede this. If you give a nitro and the pain goes away completely, are you going to give them fentanyl? No. But I would bet if you did your 12 lead before you gave the nitro, you probably didn't see huge ST elevation in 2 or more leads. Maybe you found some ST depression. And the nitro took care of the problem, the ischemia. Right? But if you really think somebody's having an MI, just get rid of their pain. Give them fentanyl. Morphine can cause vasodilation because of the histamine release. So if somebody, especially somebody having a right heart MI, be very careful about giving morphine. Very careful. Listen, do not be a dumb paramedic that gives the nitro and bottoms somebody's pressure out and then runs the IV fluids wide open to get the pressure up just to give them that second nitro. That is so stupid. And I know people who I thought were kind of smart, and then I heard them do that they did that on a call, and I thought, oh my God, dumb as a box of rocks. But that's somebody that is not understanding the pathology of what's going on. They're a cookbook paramedic. Oh, pain, give chest pain, give nitro. No. Chest pain, give fentanyl. Pain, give pain medicine. Does that not make sense, right? Give pain medicine for somebody with pain. So, are we all good on that now? Don't sit on scene to start that IV to give that first nitro. That's just the dumbest thing in the world. But I've known many people that I thought were smart that would do that kind of thing. Call a STEMI alert. Hopefully you get to go right to the cath lab. This is dumb. Provide pain relief and they have nitro under pain relief. No, nitroglycerin is not pain relief. All right, let's talk about heart failure briefly. Right versus left heart failure. Left heart failure causes fluids to back into the lungs. Right heart failure causes fluids to back into the body. It is that simple. It is that simple. Can somebody have right and left heart failure? Why, yes, they can. Yes, there's different types of heart failure, and you can look those things up, and the cardiologists know much more about the different types of heart failure than I do. But for paramedic school, what you really need to understand is 2 types. Right versus left, not the subtypes. Right versus left. And right failure without left heart failure, we said that's chlorpulmonal. You'll have fluid that backs up into the body. When it's really bad, right, when it's somebody has really bad right heart failure, you can have neck vein distension. You can see the JVD. Can anybody tell me in here how to assess accurately for JVD, the actual assessment process? I know you can because I told you guys.
Alright, we don't say that.
So tell me. Yeah. And then you compare the neck vein distension to what? The angle of what?
Oh,
Starts with an L.
Louis.
The angle of Louis. Where is the angle of Louis, everyone?
No clue. Never heard of that.
The angle of Louis is where the chest comes back to the neck, right? This part here, that angle's back. This is the angle of Louis. So if you're to accurately assess for JVD, we look at the internal jugular vein. When somebody lies flat, the external jugular vein should normally pop out. That is normal for the external jugular to pop out. Don't call someone JVD just because their external jugular is distended. That is normal. If it's flat, you might have a problem. Right? Maybe they're really hypotensive or they're bleeding out. So you find this little triangle notch right in here, this little triangle, right? You've got the sternocleidomastoid muscle. There's this little triangle. Right below that triangle, very, very shallow, a 5/8 inch needle could hit the internal jugular, right there. So you put a patient in a 45-degree angle and you have them turn their head and you compare this little area of the triangle to the angle of Louis. If there is greater than 5 centimeters of distension, that is textbook clinical JVD. How many of you have seen paramedics document JVD or no JVD, and they never put the patient in the 45-degree angle or looked at that area? Because they weren't taught appropriately. So you know how to get around that? Because you're going to have patients, you're not always going to do that. And who really cares? look for abnormal, not normal, abnormal neck vein distension. And that's what you should document. Abnormal or abnormal neck vein distension. No neck vein distension, abnormal neck vein distension. Because if this is going to bulge greater than 5 centimeters, guess what's happening to the rest of the veins in the neck? They're all bulging as well. So that's the appropriate way to assess for JVD, internal jugular vein. Or just look at neck vein distension. So with right heart failure, if it's bad enough, you can have distended neck veins. And online, I showed this to the EMT class when I did their heart or their cardio lecture. You can see there's some really great pictures with people who have, like there's this one lady, it looks like a pipe in her neck. It's so big, neck vein distension, and she was right heart failure. So you can find those pictures, you can look for yourself. How do we treat right versus left heart failure? Well, I already told you, right heart failure is dependent upon what? Starts with an F. Fluid, right? They're dependent upon preload. Preload's the pressure created by the right side of the heart. And if the right side of the heart can't create that pressure to pump blood to the lungs, we need to create the pressure for them. So we give fluids to artificially increase preload. How do we treat left heart failure?
Lasix.
Get the fluid. Who said Lasix? I'm going to hit you with my meat stick.
Oh.
Listen, I used to bring, when I ran paramedic classes, oh look, Eric, can I see your meat stick? Jim? You've got a thin meat stick. I would have a thick one. I bring the big, thick, long meat stick, and I would threaten to hit my students with the meat stick. Right? So when I say that, I'm just a habit. I say I'm going to hit you with my meat stick. So, left heart failure. Left heart failure. If they are volume overloaded, then a diuretic may be indicated. But why did paramedics get Lasix pulled out of their drug box? And in Arizona, it was way late. They did it in other states over a decade ago. Yes.
They weren't assessing correctly for pneumonia, right? They weren't.
That could be part of it, but that's not the real reason. First of all, Lasix is not a quick-acting drug. Peak effect takes longer than an hour. So, not quick-acting, and patients who were not fluid overloaded were at risk of being put into acute renal failure because their kidneys were already working hard. Oh, so let's stress the hard-working kidneys even more by giving them a loop diuretic, and they really didn't need it. Because fluid in here doesn't mean fluid overload all the time. Sometimes it's just fluid in the wrong place. So what is definitive treatment for CHF with pulmonary edema? Yes. CPAP and, yes, wonderful, CPAP and nitro. Well, wow, we found something nitro is good for. Yay. Nitroglycerin reduces afterload, so the amount of pressure that the heart has to pump against to get blood out to the body, when that is high, so quite often patients in CHF with pulmonary edema are hypertensive as well. So if we reduce that pressure that the heart has to pump against and increase the pressure in their lungs, we can shove the fluid back across the membrane into the vasculature where it belongs. Now the heart can pump it back out to the body. Does that make sense? So CPAP and nitro. I read a very interesting letter. So I used to subscribe to this magazine called Emergency. And there's gems, and there used to be these, when people actually read magazines before everything was online, there were these publications, and Emergency was a real popular one, pre-hospital one. And they published a letter that a patient wrote to a paramedic coordinator. It wasn't in the state of Arizona, I don't remember what state. Published this letter, and this guy starts out this letter saying, you know, I'd like to pass along my thanks to your paramedics. that put me in acute renal failure, and I ended up having to stay in the hospital for X amount of time longer because they gave me double dose of Lasix that I did not need. This was a very sarcastic letter. And I remember reading that letter, I'm like, oh, people are dumb. Dumb, dumb, dumb. So we used to teach, if you're going to give Lasix, if you're going to give a diuretic, double their dose. Give them double the dose. Well, guess what? If you really think about it, if I'm on 40 milligrams of Lasix once a day, and I took my 40, and it's not working, if you're going to double my dose, what do you actually give me? What should you actually give me to double my dose?
40.
Just give me another 40. Now you've doubled my dose and you've given me 80. So many people misinterpret that and they just give people 80 milligrams of Lasix on top of the 40 they already took. Well, how is that right? Then you've actually tripled the dose, not doubled the dose. And you can find that in literature, right? You can find in literature, oh, double the dose, give the patient 80 milligrams of Lasix. Well, somebody who has fragile kidneys, that can be very detrimental. Or God forbid they're on 80 milligrams and you give them 160. Now, there are patients that end up, they have gotten that much Lasix before and they do okay with it. But if I haven't taken my 40 milligrams of Lasix that day, how about you just give me the dose that I should have? Why give me 80 if I normally take 40 and I haven't taken it? Oh, well, maybe that's the problem. Give me my 40. So keep this in mind. You should have a healthy respect for everything we do because there are always consequences, right? Every action has a what? Reaction. Every time we give a drug, it does something. And hopefully it's doing something beneficial. Are there side effects? Are there potential problems? Absolutely. So you better make sure that the risks don't outweigh the benefits of what you're doing. And that's why Lasix got pulled from the drug box, because paramedics were putting patients into renal failure by giving it inappropriately. So please, well, you don't carry Lasix anymore. So the standard of care for heart failure with pulmonary edema is CPAP and nitro. CPAP and nitro. Unless they are what? What's the contraindications for CPAP? If they're allergic to CPAP, yeah, right.
Essentially, has some drugs that.
Okay, so that'd be a contraindication for nitro, but what about CPAP? Contraindications for CPAP?
They can't do applications.
Okay, altered LOC. What about hypotension? Right? Yeah, absolutely. If they're already hypotensive and their heart's not pumping well, please don't add more pressure into their chest that makes the heart pump harder for the heart to pump. Right? So ALOC and hypotension, no C. Quite often these people will be hypertensive. So nitroglycerin can help with that as well, right? Reduce the afterload, reduce their blood pressure, get the fluid out of the lungs, make everything good. Yes.
With right-sided failure, now, if you want to like get the edema out, like
We don't.
readjust.
We don't worry about the edema. Right-sided failure. So a lot of times patients who have right-sided failure, they'll get put on, sometimes with left-sided failure, if they're volume overloaded, they'll get put on a diuretic as well. But I'll tell you, there's a cardiologist that I follow on YouTube who's pretty amazing, and he says low sodium diets are absolutely dumb. There's never been a study done saying low sodium diet is good, and he's lecturing physicians, and he says all you people that are putting your patients on a low sodium diet, you're killing their kidneys. Killing the kidneys, because the kidneys are very good at conserving what? Sodium. And now you restrict the sodium the patient's taking, so the kidneys are working overtime to keep what little sodium the patient has, and you're making the kidneys worse. And then the kidneys are working harder, and then they're releasing more renin and angiotensin. And guess what? That increases vasoconstriction. And guess what that does to blood pressure? Just increases blood pressure. So low sodium diet's horrible. The body needs sodium. We're dependent upon sodium. So salt this doctor, he's awesome. And people are like, salt everything. You like salt? Salt it. He said if you don't like salt on your food a lot, take a salt tablet once a day. We're that dependent upon sodium. This doctor's really cool. I'll give you his name. If anybody's interested, I'll give you the name. You can look him up and watch him yourself. He's pretty amazing. And he's a cardiologist, prestigious cardiologist that works in Florida that was trained in London. So volume overload, sometimes patients who are considered to have volume overload and they've got a lot of swelling, they're retaining water for whatever reason, probably because their low sodium diet has killed their kidneys. Whatever, they're retaining water, they'll get put on diuretics. We don't carry diuretics, so if somebody has, remember, right-sided failure, usually it's not volume overload, it's volume in the wrong place. It's volume in the wrong place. And then you have to be really concerned when patients get put on a diuretic, because then what do they end up peeing off? They end up peeing off their potassium. So if they're on a diuretic, they probably should be on a potassium supplement as well. I used to be involved with this hospital at home program, and a lot of times these physicians would put these patients on a diuretic, right? They're CHFers, they'll put them on diuretic in the home, and they don't automatically put them on potassium. And then we would check their labs before discharge, and their potassium would be low, and oh my God, then the provider would be like, oh my God, the potassium's low, we gotta keep the patient another day, and let's give them some potassium. Well, stupid, how about you just put them on potassium when you put them on a diuretic in the first place? Does that make sense, right? So, patients who are on diuretics, you might be concerned about hypokalemia in these patients. So, what do you think happened to what happens to the T waves with hypokalemia? They flatten out, right? They flatten out. Inverted, what do inverted T waves tell us? What are they a sign of?
Ischemia.
Ischemia. But flattened out T waves can be a sign of hypokalemia, where peak T waves, sign of hyperkalemia. So if you have a patient that is on a diuretic and you ask them, do you take a potassium supplement as well? No. Guess what? Is it your job to fix their potassium problem? No, it's not. But do doctors and ERs miss things? Yes, they do. So if you're a smart paramedic, when you get that patient to the hospital, you're going to report to the nurse, hey, nurse, this patient is on daily dose of Lasix, but does not take potassium. And look at these T waves. Maybe the nurse is dumb and has no idea what you're talking about. But maybe she's smart or he's smart, and they're like, oh yeah, a patient probably should be on some potassium. So they alert the doc, right? So you're a part of the entire healthcare process. Just because it's not your responsibility doesn't mean you should be educated and know about it. It's something that simple, right? So remember, we are not teaching you to be cookbook paramedics, right? All the other paramedic programs, they're here. We want you guys to be up here. Knowledge is good, right? More knowledge is power. That's why we include so much extra in your program that a lot of other paramedic programs don't get. I've worked at a lot of places over the years and run my own paramedic programs and been hired by other places to teach theirs. And I remember going in to help out with a paramedic program for another college many years ago. You know what they got for cardiology? They got 2 days. They got 2 days to learn rhythm recognition.
That's common in the district.
2 days. And it was all done on a whiteboard, handwritten presentation. I was like, oh my God, the programs that I used to run with a nurse who used to be a business partner of mine, we would always do weeks of cardiology, 8 weeks, right? You guys get however many weeks, 6, 7 weeks of cardiology to learn EKG. 2 days. So maybe you can teach somebody what a P wave is in 2 days, that's great, and what a QRS, and you can teach what Winky Bop in 2 days, right? But can they really learn pathophysiology in 2 days? Probably not. So isn't that sad? I guarantee you, every time I call or talk to some place to place students for field, I get told, man, you guys, MCC students are so much better than other programs. They know so much more. You know, a lot of these people I've been teaching for 28 years, and there's people now that are chiefs that I had in paramedic school, and they tell me, Like, man, we can tell the difference in students from MCC than students from other programs. Their knowledge base is just so much higher. So, embrace what we're trying to teach you. I'm not trying to give you a bunch of fluff or stupid things that you'll never use, right? It's all about building your foundation of knowledge. And so now, when you, Pantha, 2 years from now, when you're sitting in a CE, maybe about cardiology, and someone starts talking about potassium, you might reach back to this day and say, oh, I remember that dumbass Chuck, he talked about this potassium. Oh, yeah, oh, now it actually makes sense what this person's saying because I got a foundation built before. Now I'm not hearing something for the first time and trying to learn it for the first time. It's building on what I already know. So that's why I teach you guys all this stuff and tell you these things. It's not to hear myself talk. It's I want you to be a good paramedic and talk the way I was taught to be a good paramedic. So you need to understand what you're doing. Let's take a break, and then we'll finish. What time is it? Oh, take 5 minutes, right? And then we'll quickly go through some other cardiovascular problems.